Hello everyone, welcome to our take-home points session for Neurology 2. Today, we will cover some fundamental aspects of neuroanatomy and neurophysiology that are essential for your understanding and preparation for the USMLE Step 1 exam. So, starting with the first question, what gives gray matter its color? Well, the gray matter appears gray because it contains neuronal cell bodies, dendrites, and unmyelinated axons, also called type C fibers. Okay? The lack of myelin, which is a fatty substance, gives gray matter its characteristic color as opposed to white matter. Easy, right? Let's proceed. And what gives white matter its color? White matter gets its color from myelinated axons. Myelin, produced by oligodendrocytes in the central nervous system, is a lipid-rich substance that insulates axons and enhances the speed of electrical signal transmission. The axons richer in myelin are called type A fibers. Also easy, right? Let's proceed. Moving forward, where is the cerebral spinal fluid, CSF, produced? Well, CSF is produced by the choroid plexuses, which are networks of blood vessels located in the ventricles of the brain. These plexuses filter blood to produce CSF, which circulates through the ventricular system and subarachnoid space. So, the choroid plexi. Also easy. Let's move on. Finally, where is the CSF absorbed? CSF is absorbed into the venous system through arachnoid granulations, which are small protrusions of the arachnoid matter into the dural venous sinuses, particularly the superior sagittal sinus. These granulations allow CSF to exit the subarachnoid space and enter the bloodstream, maintaining a balance in CSF volume and pressure.
Part 3.
Welcome to our take-home points session for Neurology 3, focusing on neuroembryology Part 1. To get started with, when does a nervous system originate? Well, the nervous system begins to develop in the third week of the embryonic life. This process starts with the formation of the neural plate, which subsequently follows to form the neural tube, the precursor to the central nervous system. So in 3 weeks, we have the neural plate. Moving forward, what is the embryological origin of a melanoma? Well, melanoma originates from neurocrest cells. These cells are multipotent and give rise to various cell types, including melanocytes, which are the pigment-producing cells of the body, especially of the skin, of course. Neurocrest cells play a crucial role in the development of many tissues and organs in the body and could give rise to melanoma. Neurocrest. Okay, let's move forward. What are the proteins involved in the neural tube orientation? That's a tricky one, but let's discuss. Well, the proteins sonic hedgehog, SHH, and WNT are key regulators in the orientation and differentiation of the neural tube. SHH is secreted from the notochord and ventralizes the neural tube, while WNT proteins are involved in dorsalizing signals. So this one is more ventralizing. This one is more dorsalizing. Okay, the balance between these signals ensures proper patterning and organization of the developing nervous system.
Part 4.
Welcome to our take-home points on neuroembryology Part 2. Starting with the first question, neural tube defects and ventral wall defects are both congenital anomalies, but they have distinct differences in their clinical and biochemical presentations. Neural tube defects involve the incomplete closure of the neural tube, leading to conditions such as spina bifida and anencephaly. These defects are characterized by increased levels of alpha-fetoprotein and acetylcholinesterase in the amniotic fluid. Ventral wall defects such as gastroschisis and omphalocele involve the failure of the ventral body wall to close properly. These defects are associated with increased AFP only, without a rise in acetylcholinesterase. Nice, right? Let's get going. For the second question, syringomyelia is a condition characterized by the development of a fluid-filled cyst, or syrinx, within the spinal cord. This condition typically affects the cervical and thoracic regions of the spinal cord. The classical clinical finding is paresthesia in a cape-like distribution. Patients may present with sensory loss over the shoulders and arms while preserving touch and proprioception, often leading to a delayed diagnosis. Moving forward, Chiari malformations are structural defects in the cerebellum. There are two main types to consider. Chiari 1 malformation involves the herniation of the cerebellar tonsils through the foramen magnum. It is often asymptomatic, but can present with headaches that are exacerbated by coughing or straining. Chiari 1 is frequently associated with the development of a syrinx, leading to syringomyelia. Okay? On the other hand, Chiari 2 malformation involves is a more severe form of the disease and involves the herniation of cerebellar tonsils, vermis, and medulla. It is typically associated with hydrocephalus and myelomeningocele, leading to symptoms such as dysphagia, stridor, and weakness. This patient is often present with severe neurological deficits early in life, and the prognosis is poor. Okay?
Part 5.
Welcome to our take-home point session on Neurology 5, Histology. Which tumor is associated with Homer right rosettes? The answer for that is medulloblastoma, a highly malignant pediatric brain tumor originating from the cerebellum or another point in the posterior fossa, but usually the cerebellum. Okay? It is characterized by small round blue cells and the presence of Homer right rosettes on histology. These rosettes are formed by tumor cells arranged in a circular pattern around a central core of neuropil. Medulloblastoma can spread via the cerebrospinal fluid, leading to drop metastases in the spinal cord. Nice! Let's move on. Next question. Which tumor arises from the Rathke's pouch? The answer for that is craniopharyngiomas, benign tumors derived from the epithelial remnants of the Rathke's pouch, an embryonic precursor of the anterior pituitary gland. These tumors are typically found in the suprasellar region and can cause symptoms by compressing the optic chiasm and pituitary gland, leading to visual disturbances and endocrine dysfunction. Histologically, craniopharyngiomas often contain cysts filled with cholesterol crystals and calcifications. Moving on. Oh, this is a good one. Which brain tumor has estrogen receptors and are more common in females? The answer for that is meningiomas, which are usually benign tumors arising from the meninges. They are more common in females, partially due to the presence of estrogen receptors on the tumor cells. Meningioma is often present with symptoms related to compression of adjacent brain structures, such as seizures or focal neurological deficits. Histologically, they are characterized by roll patterns of spindle cells and psammoma bodies. Nice. Moving on. Which marker is elevated in both pilocytic astrocytoma and GBM? Well, both pilocytic astrocytoma and glioblastoma multiforme are brain tumors derived from astrocytes and are positive for gliofibrillary acidic protein, also known as GFAP, a marker for glial cells, especially astrocytes. Pilocytic astrocytomas are benign, slow-growing tumors typically found in children. They are often located in the cerebellum and can appear cystic on imaging. Histologically, they contain Rosenthal fibers, which are eosinophilic corkscrew-shaped inclusions. On the other hand, glioblastoma multiforme, or GBM, is a highly malignant grade 4 astrocytoma. It is characterized by necrosis surrounding by pseudopalisading cells and vascular proliferation. GBM often presents with rapidly progressing neurological symptoms and has a poor prognosis.
Part 6.
Welcome to our take-home point session on neurophysiology, part 1. Which ion is a major player in neuronal depolarization? The answer for that is sodium. During an action potential, voltage-gated sodium channels open, allowing sodium ions to rush into the neuron. This influx of positive ions causes the membrane potential to become more positive, moving from the resting potential of approximately minus 70 millivolts towards a threshold of around minus 55 millivolts. Once this threshold is reached, a rapid depolarization occurs, leading to the propagation of the action potential along the axon. Moving on to the next question. Which ion is a major player in neuronal repolarization? The answer for that is potassium. Repolarization is this phase, okay? After the peak of the action potential here, voltage-gated potassium channels open, allowing potassium ion to flow out of the neuron. This efflux of positive ions causes the membrane potential to return to its resting state. The rapid outflow of potassium restores the negative charge inside the neuron, completing the repolarization phase. That's the resting membrane potential, and that's the threshold for the action potential. Our final question is, which ion is a major player in neurotransmitter exocytosis? The answer for that is calcium. When an action potential reaches the axon terminal, it triggers the opening of calcium channels, voltage-gated calcium channels, okay? The influx of calcium ions into the presynaptic terminal causes synaptic vesicles to fuse with the presynaptic membrane, releasing neurotransmitters into the synaptic cleft. This process is crucial for synaptic transmission and communication between neurons.
Part 7.
Welcome to our take-home point session on neurophysiology part 2. What are the main side effects? Phenytoin is a commonly used anti-epileptic drug, but it has several side effects that are important to remember. The first one, gingival hyperplasia, which is overgrowth of the gums here in the tooth. Hirsutism, which is excessive hair growth. Peripheral neuropathy, numbness and tingling in extremities, in case you don't know. Megaloblastic anemia due to folate deficiency. Teratogenic side effects such as fetal Hayden-Towing syndrome. Drug interactions due to cytochrome P450 enzymes. And finally, cerebellar symptoms such as ataxia and nystagmus. Quite a lot, right? The most important of them are gingival hyperplasia and hirsutism. Please remember them, okay? Let's keep going. Which AED is used to treat trigeminal neuralgia? That's a very high yield question. Carbamazepine is a first-line anti-epileptic drug used to treat trigeminal neuralgia, a condition characterized by severe facial pain. Carbamazepine works by stabilizing the inactivated state of sodium channels, reducing neuronal excitability. So it acts on sodium channels. Monitoring for side effects such as dizziness, drowsiness, Stevens-Johnson syndrome, hyponatremia, and potential hematologic abnormalities is essential when using carbamazepine, okay? Keep your mind on that. Now, moving further, which AED is dangerous in psychiatric patients? Well, the answer for that is levetiracetam. While effective as an anti-epileptic drug, it can be dangerous in patients with pre-existing psychiatric conditions. Levetiracetam has been associated with mood changes, including depression, irritability, and aggression as a side effect. Therefore, it is important to screen for a psychiatric history before initiating levetiracetam, okay? Lastly, which AEDs can actually help people with psychiatric disorders? Some anti-epileptic drugs can have positive effects on psychiatric symptoms. For example, valproic acid is used in the treatment of bipolar disorder because it stabilizes mood and reduces manic episodes. Another one, lamotrigine. It is also effective in bipolar depression because it helps in mood stabilization without the risk of inducing mania. These AEDs provide dual benefits for patients with coexisting epilepsy and psychiatric conditions, especially bipolar disorder.
Part 8.
Welcome to our take-home point session on neurophysiology part 3. Let's begin with absence seizures. Well, an absence seizure, also known as petit mal, is a generalized type of seizure characterized by sudden, brief lapses in consciousness without convulsions. Patients, often children, may appear to be staring blankly for a few seconds, and these episodes can occur multiple times a day. There is no post-ictal confusion, and patients usually resume their activities immediately after the seizure. Usually, differential diagnosis is with ADHD because the children seem to be very inattentive. And what about treatment? Well, the first-line treatment for absence seizures is ethosuximide. This medication works by inhibiting T-type calcium channels in thalamic neurons, which are involved in generating the spike and wave discharges seen on EEG during absence seizures. In case you don't remember, the waves are 3 Hz in frequency in the EEG, okay? Alternative treatments include valproic acid, which is also effective but has a broader side effect profile, so people usually prefer ethosuximide, okay? Remember that. Now, talking about the main causes for focal seizures in adults, we should remember that focal seizures originates in a specific area of the brain and can be caused by a variety of structural factors in adults. Structural. The most important of them are brain tumors, stroke, traumatic brain injury, and neuroinfections, such as meningitis, encephalitis, and brain abscesses. Basically, any structural lesion within the brain can cause focal seizures. But what about the generalized type? Generalized seizures, which affect both hemispheres of the brain from the onset, can be triggered by several metabolic factors in adults. So we'll think of metabolic, such as hypoglycemia, electrolyte imbalance, toxins, and drugs. Drug withdrawal, such as alcohol withdrawal, could also cause generalized seizures. In fact, it's very typical for an alcohol withdrawal to get a seizure.
Part 9.
Welcome to our take-home point session on neurophysiology part 4. What's the myelin function? Well, myelin is an insulating layer that surrounds the axons of neurons, produced by oligodendrocytes in the central nervous system and Schwann cells in the peripheral nervous system. The primary function of myelin is to increase the speed of electrical impulses. Increase the speed of electrical impulses or action potentials. Myelin does that in a process known as saltatory conduction. By allowing the action potential to jump from one node of Ranvier to the next, myelin reduces the time it takes for signals to travel from one part of the neuron to another. Additionally, myelin helps maintain the integrity of the signal and prevents the electrical impulses from dissipating as they travel along the axon. In conclusion, myelin is essential for efficient and rapid signal transmission within the nervous system, which is crucial for all motor and sensory functions. Moving on. Which cell is affected in MS? Multiple sclerosis is a chronic autoimmune disease that primarily affects
Part 6.
oligodendrocytes, the cells responsible for producing myelin in the central nervous system. In MS, the immune system mistakenly attacks the myelin sheath, leading to demyelination and subsequent axonal damage. And what about Guillain-Barré? Guillain-Barré syndrome, or GBS, is an acute autoimmune disorder that primarily affects Schwann cells, the cells responsible for producing myelin in the peripheral nervous system. In GBS, the immune system attacks the myelin sheath of peripheral nerves, leading to rapid onset muscle weakness and paralysis. Final question. Which are the CSF findings in MS and in Guillain-Barré? Let's split here. MS, Guillain-Barré. In MS, cerebral spinal fluid analysis often reveals the presence of oligoclonal bands, which are bands of immunoglobulins that indicate an abnormal immune response within the CNS. Elevated levels of immunoglobulin G, IgG, are also common. In Guillain-Barré syndrome, CSF analysis typically shows an elevated protein level without a corresponding increase in white blood cells, a finding known as albuminocytologic dissociation. This indicates that the blood-nerve barrier has been disrupted, leading to protein leakage into the CSF. So, a lot of proteins, but normal white blood cells in the CSF, okay?
Part 10.
Welcome to our take-home point session for Neurology 10, focusing on neurophysiology part 5. What causes Lambert-Eaton syndrome? Well, Lambert-Eaton syndrome is caused by autoantibodies against voltage-gated calcium channels. At the presynaptic nerve terminals. These autoantibodies impair the release of acetylcholine, leading to muscle weakness, which often improves with repeated use. Remember, this syndrome is commonly associated with small cell lung cancer. Okie dokie. Moving forward, what causes myasthenia gravis? Well, myasthenia gravis is an autoimmune disorder characterized by antibodies against the acetylcholine receptors at the neuromuscular junction. Acetylcholine receptors, antibodies. Okay, these antibodies block, alter, or destroy the receptors, preventing muscle contraction and leading to fluctuating muscle weakness, which worsens with activity and improves with rest. Remember, this is post-synaptic. Okie dokie. Let's move forward. Which condition responds to acetylcholinesterase inhibitors? Well, myasthenia gravis responds to acetylcholinesterase inhibitors such as pyridostigmine. The most famous one is pyridostigmine. Okay, these medications increase the amount of acetylcholine available at the neuromuscular junction, thereby improving muscle contraction and alleviating symptoms. Lambert-Eaton syndrome does not typically respond well to acetylcholinesterase inhibitors because its problem is related to calcium channels, not to acetylcholinesterase directly. So the answer for that is myasthenia gravis. Moving forward, what's the difference between Lambert-Eaton syndrome and myasthenia gravis regarding the response to muscle stimulation? That's a good one. In Lambert-Eaton syndrome, muscle strength typically improves with repeated stimulation due to the facilitation of the acetylcholine release. It will start like this and then it will improve. Okay? In contrast, myasthenia gravis exhibits a decremental response where muscle strength decreases with repeated stimulation due to the progressive depletion of functional acetylcholine receptors. It will go like this.
Part 11.
Welcome to our take-home point session for Neurology 11, focusing on nerve roots. Name the nerve roots of the hands and feet. Well, the nerve roots that innervates the hands are primarily C6, C7, and C8. C6 is responsible for thumb sensation. C7 for the middle finger, and C8 for the pink finger or little finger. For the feet, The nerve roots are primarily L4, L5, and S1. L4 supplies the medial aspect of it, this region here. L5, the dorsum of the foot. L5. And L6, no, S1, the lateral aspect and the heel. S1. So medial, dorsum, lateral, and also heel. Okay, let's move forward. Localize the affected nerve root through description. Well, to identify the affected nerve root, you need to assess sensory and motor deficits, as well as reflex changes. For example, weakness in wrist extension and sensory loss over the thumb. Let's suppose we have a hand here, and we lost sensation over the thumb and wrist extension. This suggests C6 lesion. Okay? Weakness in ankle dorsiflexion and sensory loss over the dorsum of the foot. Now we're talking about feet, and we lost the dorsum of the foot, and we also lost the ankle dorsiflexion. This is most likely an L5 lesion. Okay? Patellar reflex changes suggest L4 involvement, while Achilles changes point to S1 problems. Okay? Good. Let's move forward. Name the possible diseases associated with nerve roots. Well, conditions affecting nerve roots include radiculopathies, which are often due to herniated discs. Well, or spinal stenosis. For example, cervical radiculopathy can cause neck pain radiating to the arm, while lumbar radiculopathy can cause low back pain radiating to the leg. Other conditions like herpes zoster can cause radicular pain plus rash.
Part 12.
Welcome to our take-home point session for Neurology 12, focusing on peripheral nerves. First question, name the most important nerves from the upper and lower limbs. Well, for the upper limb, let me draw here. I'm not the best drawer. This is palm. This is dorsum of the hand. Okay? Well, the key nerves are the median, the ulnar, and the radial nerve. The median nerve is responsible for the motor innervation of most of the forearm flexors and the thenar muscles here, and it provides sensory innervation to the palmar side of the thumb, the index, the middle, and half of the ring finger. So this all here is median nerve. The ulnar nerve innervates the flexor carpi ulnaris and the intrinsic muscles of the hand, providing sensory innervation to the medial half of the ring, this, and the little finger. This here, and also this here as well, is ulnar nerve. Okay. Lastly, the radial nerve controls the extensors of the arm and the forearm and provides sensory innervation to the posterior aspect of the arm and hand. So this here is radial. For the lower limb, the important nerves are the femoral, the sciatic, and the obturator nerves. The femoral nerves anteriorly innervates the quadriceps. Femoral quadriceps, and provides sensory input to the anterior thigh and medial leg, mostly the anterior thigh. Okay? The sciatic nerve innervates the hamstring muscles, which are the opposite of the quadriceps muscles, and it splits into the tibial and common peroneal nerves, which supply the lower leg and the foot. Tibial and common peroneal or common fibular, it's the same nerve. Lastly, the obturator nerve innervates the adductor muscles of the thigh and provides sensory innervation to the medial thigh as well. Okay, let's move forward. Well, differentiate between nerve root distribution and peripheral nerve distribution. Nerve root distribution, or radiculopathy, refers to symptoms that follow a dermatomal or myotomal pattern, indicating compression of irritation of a spinal nerve root. For example, a C6 radiculopathy might cause pain and sensory loss in the thumb and weakness in wrist extension. In contrast, peripheral nerve distribution involves symptoms that follow the specific distribution of a peripheral nerve, which can include multiple spinal nerve roots. For instance, peripheral nerve, carpal tunnel syndrome affects the median nerve, causing symptoms in the thumb, the index, the middle, and the lateral half of the ring finger, regardless of the specific spinal nerve roots involved, which are many. Understanding these differences helps in accurately diagnosing and managing various neurological conditions.
Part 13.
Welcome to our take-home point session for Neurology 13, focusing on the spinal cord. Let's start. Memorize the 4 major tracts in the spinal cord. Well, the 4 key tracts and structures are the cortico spinal tract, the anterior horn, the spinothalamic tract, and the posterior or dorsal column. Well, the cortical spinal tract, also known as the pyramidal tract or pyramidal tract, is responsible for voluntary motor control, with fibers crossing in the medulla, not in the spinal cord. The cortical spinal tract connects to the anterior horn that will then connect to the muscles. Lesions in the cortical spinal tract will lead to upper motor neuron syndrome, while lesions in the anterior horn will lead to lower motor neuron syndrome. Okay? The upper motor neuron syndrome will lead to hypertonia, weakness and hypertonia. The lower motor neuron syndrome will lead to weakness with hypotonia and hyporeflexia as well. Moving forward, the spinothalamic tract carries pain and temperature sensations, with fibers crossing at the level of entry in the spinal cord. The dorsal columns, which include the fasciculus gracilis and fasciculus cuneatus, transmit fine touch, vibration, and proprioception, with fibers crossing also in the medulla, not in the spinal cord. Lesions in the spinothalamic tract will lead to loss of crude touch, pain, and temperature sensation, while lesions in the dorsal column will lead to loss of proprioception, vibration, and fine touch. Easy, right? Let's proceed. Associate the spinal cord syndrome to a specific etiology. Understanding the clinical presentation and underlying cause of spinal cord syndromes is crucial. For instance, anterior cord syndrome is typically caused by ischemia or trauma, and it affects the anterior horn, the cortical spinal tract, and the spinothalamic tract, leading to a loss of motor function and pain and temperature sensations below the lesion. Now, central cord syndrome, often resulting from hyperextension injuries, cervical spondylosis, or syringomyelia. Syringomyelia is the most important for your exam. Affects the central part of the spinal cord, especially the spinothalamic tract and the anterior horn, causing greater weakness in the upper limbs than in the lower limbs. Brown-Séquard syndrome, caused by hemisection of the spinal cord due to trauma or tumors, results in ipsilateral loss of motor function and proprioception, and contralateral loss of pain and temperature sensations. Posterior cord syndrome, which can be due to neurosyphilis or tabes dorsalis, another name for neurosyphilis, primarily affects the dorsal columns, leading to loss of fine touch, vibration, and proprioception below the level of the lesion. Vitamin B12 deficiency affects both the posterior column, but also the cortical spinal tract.
Part 14.
Welcome to our take-home points session for Neurology 14, focusing on cranial nerves. Get to know the function of each of the cranial nerves and their approximate location. There are 12 cranial nerves, each with specific functions and locations. Okay? The first one, the olfactory nerve, is responsible for smell. Sense of smell located in the olfactory epithelium. The second one, the optic nerve, transmits visual information from the retina to the brain, located in the optic canal. It controls vision. The third one, the oculomotor nerve, controls most of the eye movements and pupil constriction, and maintains an open eyelid. Its nuclei is located in the midbrain. The fourth one is the trochlear nerve that innervates the superior oblique muscle, which controls rotational movements of the eye, also located in the midbrain. The fifth one is one of the most important nerves, the trigeminal nerve, provides sensation to the face. Face sensation. And motor functions for mastication. Mastication. It has three branches, the ophthalmic, the maxillary, and the mandibular branch, located in the palms. And the sixth nerve is the abducens nerve that controls the lateral rectus muscle, responsible for abduction, okay? For the outward gaze. Well, the facial nerve is responsible for controlling the muscles of facial expression. Facial expression. It also controls taste sensations through the anterior 2/3 of the tongue and supplies glands. It is located in the palms. The vestibulocochlear nerve is responsible for hearing and balance. It is located in the inner ear. The glossopharyngeal nerve provides taste sensation from the posterior 1/3 of the tongue and innervates the pharynx. It's located in the medulla. The vagus nerve controls the heart, the lungs, the GI tract, and provides sensation to the ear and part of the throat. It is located in the medulla as well. The accessory nerve innervates the sternocleidomastoid and trapezius muscles. It is located in the spinal cord, also in the medulla. And finally, the hypoglossal nerve controls tongue movements. Tongue movements, also located in the medulla. Now, associate the given cranial nerve with specific diseases. Let's start. The olfactory nerve will lead to anosmia that is often caused by head trauma or neurodegenerative diseases like Parkinson. Parkinson's disease loves to affect the olfactory nerve. Okay? Now, the optic nerve, there's a bunch of them, but I'll quote here optic neuritis, commonly associated with multiple sclerosis. Okay? The oculomotor nerve, if it is affected, it can lead to oculomotor nerve palsy, often caused by diabetes or aneurysms, leading to ptosis, double vision, and pupil dilation. The eye will look like this, down and out gaze. The trochlear nerve palsy can lead to vertical diplopia and difficulty in downward gaze, commonly from trauma. The trigeminal nerve could be affected in trigeminal neuralgia, causing severe facial pain triggered by compression from blood vessels. The abducens nerve could be affected in abducens nerve palsy, leading to inability to move the eye outward, commonly caused by increased intracranial pressure. The facial nerve could be affected in Bell's palsy, causing unilateral facial paralysis, often idiopathic or viral. Well, the vestibulocochlear nerve could be affected in vestibular neuritis or labyrinthitis, causing vertigo and hearing loss, and it's often viral. The glossopharyngeal nerve could be affected in a more rare condition, the glossopharyngeal neuralgia as well, causing severe throat pain, often triggered by swallowing. The vagus nerve dysfunction, which could be, for example, due to surgeries, post-surgery, could lead to voice changes, difficulty swallowing, and heart rate abnormalities, often due to surgeries, like I said, or tumors. The accessory nerve could be affected in the accessory nerve palsy, leading to weakness in shoulder elevation and head rotation, commonly from surgical injury as well. And finally, oh, sorry guys, this. My Roman numbers are crazy right now. So, the hypoglossal nerve palsy will cause tongue deviation and atrophy, often from tumors, or more commonly, stroke.
Part 15.
Welcome to our take-home point session for Neurology 15, focusing on the brainstem. Well, general signs of brainstem lesions include cross signs, which are characterized by ipsilateral cranial nerve deficits and contralateral body sensory or motor deficits. This unique presentation occurs because the cranial nerves emerge from the brainstem and affect the same side of the body, while the sensory and motor pathways cross over to the opposite side of the body. Okay, let's keep going. In the medulla, there are two key syndromes to remember. Medial medullary syndrome, or Dejerine syndrome, is caused by occlusion of the anterior spinal or vertebral artery, usually the vertebral artery. It presents with contralateral weakness and loss of sensation, along with ipsilateral tongue palsy. Lateral medullary syndrome, or Wallenberg syndrome, is due to occlusion of the posterior inferior cerebellar artery, also known as pica. It presents with contralateral loss of pain and temperature sensation in the body, ipsilateral loss of sensation in the face, imbalance, ataxia, dizziness, dysphonia, dysarthria, dysphagia, and Horner syndrome. It's a lot. Let's proceed. Oh, it's Wallenberg. Please, do not commit this mistake. Moving forward, in the pons, medial pontine syndromes are typically caused by occlusion of the basilar artery. Okay? These syndromes present with contralateral weakness, due to corticospinal tract involvement, ipsilateral facial palsy from the facial nerve, contralateral sensory loss from the medial lemniscus, internuclear ophthalmoplegia due to medial longitudinal fasciculus involvement, also known as MLF, ipsilateral abduction impairment from the abducens nerve, and decreased level of consciousness if the reticular activating system or RAFI nucleus is activated. Effect. Lateral pointing syndromes, often caused by occlusion of the anterior inferior cerebellar artery, also known as ICA, presence with contralateral loss from the spinothalamic tract, ipsilateral facial palsy from the facial nerve, ipsilateral facial sensory loss from the trigeminal nerve, and balance and hearing problems from the vestibulocochlear nerve. Okay? Well, in the midbrain, medial midbrain syndromes, often due to basilar artery occlusion, presence with contralateral weakness, ipsilateral oculomotor palsy, and Parkinsonian features due to involvement of the substantia nigra. This syndrome is also known as Weber syndrome. Lateral midbrain syndromes involve the superior colliculus and are typically associated with pinealomas. This syndrome is present with upward gaze impairment, argyrobatson pupil, and convergence retraction nystagmus. This presentation is also known as Paris-Nose syndrome.
Part 16.
Welcome to our take-home point session for Neurology 16, focusing on the limbic system. Well, the hypothalamus is a critical component of the limbic system, regulating various autonomic and endocrine functions. Different lesions in the hypothalamus can lead to specific disorders. A posterior hypothalamic lesion can cause hypothermia, while an anterior lesion can result in hyperthermia. A lateral hypothalamic lesion leads to weight loss due to loss of appetite, whereas a medial lesion causes weight gain. A lesion in the preoptic area can result in hypogonadism, affecting reproductive functions. The suprachiasmatic nucleus regulates circadian rhythms, and its lesion can cause sleep disorders. The supraoptic nucleus is involved in the release of antidiuretic hormone, or ADH, crucial for water balance, while the periventricular nuclei release oxytocin, important for uterine contractions and lactation, mostly uterine contractions. Okay? Let's move forward. Well, the thalamus acts as the brain's relay station for sensory and motor signals, mostly sensory. The lateral geniculate body is responsible for vision, relaying visual information from the retina to the visual cortex. The medial geniculate body is involved in hearing, transmitting auditory information to the auditory cortex. The ventral posterior medial nucleus processes sensory information from the face and taste, while the ventral posterolateral nucleus handles sensory input from the body, including touch, pain, and temperature. The epithalamus includes the pineal gland, which secretes melatonin. Melatonin is crucial for regulating sleep-wake cycles and circadian rhythms. It responds to light and darkness, promoting sleep in response to darkness and helping maintain the body's internal clock. And finally, the subthalamus plays a vital role in motor control. A lesion in the subthalamus can lead to hemiballismus, characterized by involuntary flinging movements of the limbs on one side of the body. This condition results from damage to the subthalamic nucleus, which disrupts the regulation of motor pathways.
Part 17.
Welcome to our take-home point session for Neurology 16, focusing on the limbic system. The hypothalamus is a critical component of the limbic system, regulating various autonomic and endocrine functions. Different lesions in the hypothalamus can lead to specific disorders. A posterior hypothalamic lesion can cause hypothermia, while an anterior lesion can result in hyperthermia. A lateral hypothalamic lesion leads to weight loss due to loss of appetite, whereas a medial lesion causes weight gain. A lesion in the preoptic area can result in hypogonadism, affecting reproductive functions. The suprachiasmatic nucleus regulates circadian rhythms, and its lesion can cause sleep disorders. The supraoptic nucleus is involved in the release of antidiuretic hormone, or ADH, crucial for water balance, while the periventricular nuclei release oxytocin, important for uterine contractions and lactation, mostly uterine contractions. Okay? Let's move forward. Well, the thalamus acts as the brain's relay station for sensory and motor signals, mostly sensory. The lateral geniculate body is responsible for vision, relaying visual information from the retina to the visual cortex. The medial geniculate body is involved in hearing, transmitting auditory information to the auditory cortex. The ventral posterior medial nucleus processes sensory information from the face and taste, while the ventral posterolateral nucleus handles sensory input from the body, including touch, pain, and temperature. The epithalamus includes the pineal gland, which secretes melatonin. Melatonin is crucial for regulating sleep-wake cycles and circadian rhythms. It responds to light and darkness, promoting sleep in response to darkness and helping maintain the body's internal clock. And finally, the subthalamus plays a vital role in motor control. A lesion in the subthalamus can lead to hemiballismus, characterized by involuntary flinging movements of the limbs on one side of the body. This condition results from damage to the subthalamic nucleus, which disrupts the regulation of motor pathways.
Part 18.
Welcome to our take-home point session for Neurology 18, focusing on stroke and vascular neurology. Let's start by discussing the clinical features of strokes affecting different arteries. Strokes in the anterior cerebral artery, or ACA, typically cause weakness and numbness in the legs due to its supply to the medial portions of the frontal and parietal lobes. In contrast, strokes in the middle cerebral artery, or MCA, often leads to weakness and numbness in the arms and face, aphasia if the dominant hemisphere is affected, neglect if the non-dominant hemisphere is affected, and visual symptoms due to its supply to the lateral aspects of the frontal, parietal, and temporal lobes, which contains the optic pathway. Well, the lenticulus striate branches of the MCA supply the internal capsule and basal ganglia. Strokes in these branches can cause pure motor deficits if the internal capsule is involved, or movement disorders if the basal ganglia is affected. The thalamus, supplied by branches of the posterior cerebral artery, when involved in a stroke, can lead to pure sensory deficits. So we're talking more about the anterior circulation here. Let's now talk about the posterior one. Strokes in the posterior cerebral artery, or PCA, primarily cause visual deficits due to its supply to the occipital lobe. It could also cause sensory deficits if the PCA branches to the thalamus are affected. Thalamus. Good. The posterior inferior cerebellar artery, also known as pica, which supplies the lateral medulla, when occluded, results in Wallenberg syndrome. The syndrome is present with symptoms such as contralateral loss of pain and temperature sensations. In the body, ipsilateral facial sensory loss, ataxia, dysphagia, and Horner syndrome. The anterior inferior cerebellar artery, also known as ICA, supplies the lateral pons. Strokes here can cause facial paralysis and sensory deficits, as well as hearing and balance problems due to the involvement of the facial and vestibulocochlear nerve. Let's also add here the vestibulocochlear nerve. Okay, now moving on. Occlusion of the basilar artery, one of the main arteries we have, can result in locked-in syndrome, characterized by quadriplegia and the inability to speak, while retaining consciousness and eye movements. Terrible situation. Let's move on. Lastly, let's discuss the different types of ischemic and hemorrhagic strokes. Ischemic strokes can be due to large artery disease, such as cardioembolic or atriothrombotic events, and small artery disease leading to lacunar strokes. Hemorrhagic strokes can occur in different regions. Lobar or cerebellar hemorrhages are often caused by cerebral amyloid angiopathy, while basal ganglia or brainstem hemorrhages are usually due to lipohyalinosis or microaneurysm associated with hypertension. Global hypoxic ischemic injury affects the most vulnerable areas of the brain, such as the hippocampus, the cerebellum, and the watershed areas, typically resulting from systemic hyperperfusion due to, for example, a cardiac arrest.
Part 19.
Welcome to our take-home point session for Neurology 19, focusing on increased intracranial pressure, or ICP. Let's start by discussing the flow of the cerebral spinal fluid, CSF, and the cerebral perfusion. Well, CSF is produced by the choroid plexus within the ventricular system. It flows through the ventricles and into the subarachnoid space, circulating around the brain and spinal cord. The CSF is eventually absorbed into the cerebral sinuses and drains into the jugular vein. Maintaining proper cerebral perfusion is critical for brain function. Cerebral perfusion pressure, CPP, is calculated as the mean arterial pressure, MAP, minus the intracranial pressure, also known as ICP. Well, increased intracranial pressure can result from several causes, including stroke, hydrocephalus, trauma, tumors, and infections. Common signs and symptoms of increased ICP include vomiting, headache, papilledema, which is a swelling of the optic disc, and the Cushing's triad, which consists of hypertension, bradycardia, and irregular respirations. Recognizing these symptoms is crucial for prompt diagnosis and management. Now, just to refresh, the Cushing's triad is hypertension, bradycardia, and irregular respirations. Okay, let's move on. Well, hydrocephalus is a condition characterized by an abnormal accumulation of CSF within the brain's ventricle. It can be classified as communicating versus non-communicating. The classical example of communicating is meningitis, and the classical example of non-communicating are brain tumors. Okay? Well, let's talk about specific cases. Normal pressure hydrocephalus presents with a classic triad of symptoms: magnetic gait, urinary incontinence, and dementia. This triad is very important for your exam, so please remember that. Brain hemorrhages can be categorized by their location and appearance on imaging. Epiduromatomas, typically biconvex, result from arterial bleeding, often involving the middle meningeal artery, and present with a lucid interval. Subdural hematomas are crescent-shaped and result from venous bleeding involving bridging veins. And finally, subarachnoid hemorrhages, often caused by aneurysm or arteriovenous malformations, AVMs, present with a thunderclap headache. Now, brain herniations occur when increased ICP causes brain tissue to shift from its normal position. There are several types of brain herniation. Subfalcine herniation involves displacement of the cingulate gyrus under the falx cerebri, compressing the anterior cerebral artery and causing signs of ACA compression. Transtentorial or central herniation involves downward displacement of the brainstem, leading to progressive neurological deterioration, presenting with decortication or decerebration. Uncal herniation involves displacement of the uncus of the temporal lobe, compressing the midbrain and leading to ipsilateral oculomotor nerve palsy and contralateral hemiparesis. And finally, tonsillar herniation involves displacement of the cerebellar tonsils through the foramen magnum, compressing the medulla oblongata and presenting with Cushing's triad, hypertension, bradycardia, and irregular respirations.
Part 20.
Welcome to our take-home point session for Neurology 20, focusing on ophthalmology. Let's begin with the optic pathway and its lesions. Damage to the optic nerve or eyeball results in monocular vision loss. A lesion at the optic chiasm leads to bitemporal hymenopia, affecting the temporal visual fields of both eyes. Damage to the optic tract causes homonymous hymenopia, where the same side of the visual field is lost in both eyes. Lesions in the optic radiation lead to quadrantanopia, affecting a quarter of the visual field. Finally, damage to the occipital cortex results in homonymous hymenopia with macular sparing due to dual blood supply to the macula. Cranial nerve palsies can significantly affect eye movements. The oculomotor nerve palsy results in down and out eyes due to unopposed action of the lateral rectus and superior oblique muscles. That's this one here. This nerve has motor and parasympathetic components. Remember that. Lesions to the oculomotor nerve can also lead to mydriasis. Internuclear ophthalmoplegia is characterized by failure of one eye to adduct in response to contralateral eye abduction, often seen in multiple sclerosis. Internuclear ophthalmoplegia, and this is due to damage to the medial longitudinal fasciculus. Okay? Abducens nerve palsy causes inability to abduct the eye, and the trochlear nerve palsy results in up and in eyes due to superior oblique muscle dysfunction. Now let's just refresh oculomotor, internuclear ophthalmoplegia, abducens, and the trochlear. Fine. Let's move on. Conjunctivitis can be viral, bacterial, or allergic. Viral conjunctivitis typically presents with watery discharge and pre-auricular lymphadenopathy. Bacterial conjunctivitis is characterized by purulent discharge and requires antibiotic treatment. Allergic conjunctivitis presents with itching, redness, and watery discharge, often in response to allergens. Okay, moving forward. Uveitis is an inflammation of the uveal tract, which includes the iris, the ciliary bodies, and the choroid. It presents with red eye, pain, and vision loss. Uveitis is often associated with autoimmune diseases such as ankylosing spondylitis and sarcoidosis, and requires prompt treatment to prevent complications. Well, refractive errors include myopia or nearsightedness, corrected with diverging lenses, hyperopia, farsightedness, corrected with converging lenses, and astigmatism, caused by any irregularly shaped cornea, corrected with cylindrical lenses. Now, talking about one of the most important diseases in ophthalmology, cataracts involve the clouding of the lens, leading to decreased vision. Risk factors include steroid use, diabetes mellitus, galactosemia, and congenital infections like thrush. Cataract surgery is a common and effective treatment. Now, one of the most important diseases, glaucoma, is characterized by increased intraocular pressure, leading to optic nerve damage. Open-angle glaucoma develops gradually and is more common, while closed-angle glaucoma can be acute and worsens with mydriasis. Treatment include medications to reduce aqueous humor production, such as beta blockers and alpha agonists, or to increase its outflow, such as cholinergics and prostaglandin analogs. Finally, retinopathies with neovascularization, such as those seen in diabetes mellitus and age-related macular degeneration, can be treated with anti-VEGF therapies to inhibit abnormal blood vessel growth and reduce vision loss. A specific type of retinopathy, retinitis pigmentosa, is an inherited condition characterized by progressive peripheral vision loss and night blindness due to the accumulation of dark pigments in the retina. It leads to gradual vision loss and can ultimately result in blindness.
Part 21.
Hello everyone, welcome to our take-home point session for Neurology 21, focusing on movement disorders. Well, the basal ganglia are critical for regulating movement. The direct pathway is excitatory and facilitates movement. This pathway involves the striatum inhibiting the globus pallidus internus, which in turn reduces inhibition of the thalamus, leading to increased thalamic excitation of the motor cortex. Movement. Okie dokie. In contrast, the indirect pathway is inhibitory and suppresses movement. It suppresses movement. Okay. In this pathway, the striatum inhibits the globus pallidus externus, which normally inhibits the subthalamic nucleus. Reduced inhibition of the subthalamic nucleus leads to increased stimulation of the globus pallidus internus, which then inhibits the thalamus more, reducing thalamic excitation of the motor cortex. Several dopamine pathways are important for different functions. The mesolimbic pathway is associated with hallucinations when overactive. The tubero-infundibular pathway regulates prolactin and can lead to hyperprolactinemia if disrupted. The mesocortical pathway is involved in motivation and cognitive function, and its disruption can lead to apathy. And finally, the nigrostriatal pathway is crucial for movement control, and its degeneration leads to movement disorders like Parkinson's disease. Talking about Parkinson, let's discuss medication used in Parkinson's disease. Levodopa is a precursor to dopamine and directly increases dopamine levels in the brain, improving motor symptoms in Parkinson's disease. Levodopa. Okay. Medications that decrease levodopa clearance out of the brain include dopa decarboxylase or DDC inhibitors, such as carbidopa, and COMT inhibitors, such as tocopone and entacapone. These drugs help increase the availability of levodopa in the brain. DCC inhibitors and COMT inhibitors. Remember that. Now, to decrease dopamine clearance within the brain, male inhibitors such as selaginine and COMT inhibitors such as tocopone are used. Selaginine, tocopone. Entacapone is only outside the brain. It does not work within the brain. Tocopone works within the brain and outside the brain. Remember that. All of these drugs inhibit the breakdown of dopamine, increasing its availability in the synaptic cleft. Well, medications like amantadine work by decreasing dopamine reuptake in the synaptic cleft, further increasing dopamine levels available for signaling. And finally, dopaminergic agents such as bromocriptine, pramipexole, and ropinirole mimic the effects of dopamine by stimulating dopamine receptors directly. Common side effects of these medications and of dopamine itself include nausea, hallucinations, and hypotension. Parkinson's disease typically presents with an asymmetric resting tremor, more common in elderly patients. The underlying pathophysiology involves degeneration of the substantia nigra and the presence of Lewy bodies, which are abnormal aggregates of protein. Now, going away from the Parkinson's subject, let's talk about different movement disorders. Essential tremor is a symmetric intention tremor that occurs during voluntary movement. It is often hereditary and affects younger individuals. Treatment typically includes beta blockers. Now, chorea and athetosis involve dance-like involuntary movements, often affecting the body and the fingers. These movements can be seen in conditions such as rheumatic fever and Huntington's disease. Just to refresh your memory, chorea is involved in the body abnormal dance-like movements, while athetosis only involves the fingers. Okay? Now, myoclonus and asterix, which is a specific type of myoclonus, are characterized by sudden rhythmic movements. These can affect the body and hands and are often seen in renal and liver failure. Now, let's talk about one of the most prevalent movement disorders. Akathisia is a condition characterized by a desperate urge to move, often a side effect of neuroleptic drugs and metoclopramide. It's a very common movement disorder in the ED. So, let's continue. Dystonia involves involuntary, sustained, painful muscle contractions. Treatment often includes botulinum toxin, or Botox, injections to relieve muscle spasms. And finally, hemiballismus is characterized by sudden, high-amplitude movements, typically affecting one side of the body. It is often caused by a stroke in the subthalamic nucleus.
Part 22.
Hello everyone, welcome to our take-home point session for Neurology 2022. Focusing on epilepsy. Let's begin with definitions. A seizure is a focal episode of neuronal hyperactivation. Status epilepticus refers to a seizure lasting more than 5 minutes with loss of consciousness. Epilepsy is a chronic condition characterized by a predisposition to recurrent seizures. So you can have a seizure, but it does not mean you'll need to have epilepsy. Seizures can be classified into different types based on their etiology. Provoked seizures are often caused by factors such as hypoglycemia, electrolyte imbalances, and drugs. Epileptic seizures can be acquired or hereditary, resulting from underlying neurological conditions. And finally, non-epileptic seizures, also known as psychogenic seizures, are related to psychological factors rather than electrical disturbances in the brain. Generalized seizures involve both hemispheres of the brain and include tonic-clonic, atonic, and absent seizures. These seizures often have a provoked etiology. Tonic seizures involve sustained muscle contractions. Clonic seizures are characterized by rhythmic jerking, and tonic-clonic seizures combine both features. Atonic seizures involve a sudden loss of muscle tone, while absent seizures are brief and involve staring spells. Now, focal seizures originate in one hemisphere of the brain and can be simple or complex. Simple focal seizures do not impair consciousness, whereas complex focal seizures do. The symptoms of focal seizures depend on the affected brain region. For example, temporal lobe seizures may involve auditory or emotional disturbances, while frontal lobe seizures can cause motor symptoms. Parietal lobe seizures, often present with sensory disturbances, and occipital lobe seizures can cause visual symptoms. Focal seizures are often acquired and can result from brain injuries or lesions. Moving a bit further, let's talk about anticonvulsant drugs. Anticonvulsant drugs, or AEDs, are classified based on their mechanism of action. GABA agonists enhance inhibitory neurotransmission. These include benzodiazepines, phenobarbital, topiramate, valproic acid, and vigabatrin. Sodium channel blockers stabilize neuronal membranes and include carbamazepine, phenytoin, lamotrigine, and lacosamide. Calcium channel blockers reduce neuronal excitability and include levetiracetam, gabapentin, and ethosuximide. Let's talk a bit more about them. Benzodiazepines are a first-line therapy for status epilepticus due to their sedative properties. Phenobarbital is effective, but can cause sedation and drug interactions due to cytochrome P450 induction. Topiramate also acts as a sodium channel blocker and can cause kidney stones and cognitive side effects. Vigabatrin can lead to vision loss, and valproic acid also acts as a sodium channel blocker like topiramate and can cause metabolic syndrome, birth defects, and hepatotoxicity. It can also cause plaquetopenia. Next, let's review sodium channel blockers. Carbamazepine can cause drug interactions, cerebellar symptoms, blood dyscrasias, hepatotoxicity, birth defects, Stevens-Johnson syndromes, and hyponatremia due to SIADH. Phenytoin has similar side effects, including hirsutism, gingival hyperplasia, osteopenia, neuropathy, drug-induced lupus, and birth defects. Lamotrigine is associated with Stevens-Johnson syndrome, and lacosamide can cause cerebellar symptoms. Lastly, let's cover calcium channel blockers. Ethosuximide is a first-line therapy for absence seizures. Levetiracetam can cause mood instability, and gabapentin is often used for neuropathic pain in addition to its anticonvulsant properties, which are low.
Part 23.
Hello everyone, welcome to our take-home points session for Neurology 23, focusing right now on anesthesia and headache. Today, we'll cover different types of anesthetic agents, their properties and side effects, as well as various types of headaches and their management. Anesthetic agents are categorized into three main types: analgesics, sedative hypnotics, and neuromuscular blockers. Analgesics are used for pain relief, sedative hypnotics for inducing sleep and reducing anxiety, and neuromuscular blockers for muscle relaxation during surgical procedures. Anesthetic agents vary in their absorption and potency based on their lipophilicity and hydrophobicity. More lipophilic agents are more potent because they are absorbed better into the fat tissues. More hydrophobic agents have a quicker onset and recovery because they are absorbed faster into the blood. The minimum alveolar concentration, or MAC, is a measure of potency. The lower the MAC, the higher the potency of an inhaled anesthetic. Okay? Let's move on. Opioid analgesics are powerful pain relievers but come with significant side effects, such as meiosis, constipation, vomiting, addiction, and cardiorespiratory depression. Withdrawal symptoms include the opposite: mydriasis, diarrhea, vomiting, tremor, and agitation. Partial agonists like buprenorphine can induce withdrawal symptoms if the patient has been using full agonists like fentanyl. The antidote for opioid overdose is, of course, naloxone. Remember that. Topical anesthetics can be divided into amides like lidocaine and bupivacaine, and esters like tetracaine. They are often used with vasoconstrictors to reduce side effects and enhance their effect. Common side effects include perioral tingling and cardiorespiratory arrest. Moving further, hypnosedative agents work by enhancing GABAergic activity. Benzodiazepines like midazolam are effective but can cause addiction and respiratory depression. Barbiturates like thiopental also carry risks of drug interactions, addiction, and respiratory depression as well. Propofol is widely used, but can cause cardiorespiratory depression and hypertriglyceridemia that's very high yield. Ketamine, an NMDA antagonist, has sympathetic effects and can cause dissociation. Inhaled anesthetics, like halothane and sevoflurane, can cause hepatotoxicity, while methoxyflurane can cause nephrotoxicity. A common serious side effect of these drugs is malignant hypothermia, which is treated with dantrolene. Neuromuscular blockers are used to induce muscle paralysis. Depolarizing agents like succinylcholine can cause hyperkalemia and malignant hyperthermia. Non-depolarizing agents like cisatracurium and rocuronium are also used, and they block nicotinic and muscarinic receptors. Now finally, let's talk about the headaches. Headaches are categorized into tension headaches, migraine, and cluster headaches. Tension headaches are mild, band-like, and bilateral. They can be treated acutely with paracetamol or NSAIDs, and chronic tension headaches can be managed with tricyclic depressants. Vou só repetir essa última frase. And chronic tension headaches can be managed with chronic tension headaches can be managed with tricyclic antidepressants. Migraines are intense, throbbing, and unilateral, often accompanied by photophobia, phonophobia, and nausea. Acute treatment involves paracetamol, NSAIDs, triptans, and ergoderivatives. Chronic management involves tricyclics, beta blockers, dual antidepressants, and anticonvulsants. The last one, cluster headaches, are excruciating and periorbital, often associated with rhinorrhea and red eyes, lacrimation, and Horner syndrome. Acute treatment includes oxygen and triptans, while chronic treatment may involve verapamil.
Part 24.
Welcome to our take-home point session on neurodegenerative and demyelinating disorders. Let's begin with the general treatment approach for dementia. The mainstay of treatment includes acetylcholinesterase inhibitors such as donepezil, which increase acetylcholine levels in the brain to help improve memory and cognition. NMDA antagonists like memantine are also useful to reduce glutamate excitotoxicity and provide neuroprotection. Alzheimer's disease is characterized by intracellular neurofibrillary tangles composed of tau proteins and extracellular plaques formed by beta amyloid, a breakdown product of amyloid precursor protein. The risk of Alzheimer's is influenced by the ApoE enzyme. The ApoE2 allele decreases the risk, while the ApoE4 allele increases the risk. Clinically, Alzheimer's primarily affects memory and visual spatial skills, with early involvement of the hippocampus. Dementia can be classified into several types based on their clinical features and pathological features. Alzheimer's disease, as already said, affects memory and visual spatial skills, with early hippocampal involvement. Frontotemporal dementia primarily affects behavior, language, and executive functions. Vascular dementia presents with a stepwise decline in cognitive function and is often associated with a history of strokes. It mainly affects behavior and executive functions. Creutzfeldt-Jakob disease is a rapidly progressive dementia with myoclonus caused by prion disease. Lewy bodies dementia is characterized by dementia with Parkinsonian features, plus vivid visual hallucinations associated with alpha-synuclein deposits. And finally, Huntington's disease is an autosomal dominant disorder with CAG trinucleotide repeat expansions leading to behavioral changes and caudate atrophy. ALS involves both upper and lower motor neuron degeneration, leading to muscle weakness and atrophy. Patients typically have intact cognition. Treatment with riluzole and NMDA antagonists can slow disease progression. The disease affects the brain, the brainstem, the cerebellum, and the spinal cord. MS is a demyelinating disease more common in females and in areas with low sun exposure. It can also affect the brain, the brainstem, the cerebellum, and the spinal cord, and it has a relapsing remitting course, and can present with optic neuritis, internuclear ophthalmoplegia or INO, and Marcus-Gahn pupil. Diagnosis is supported by finding oligoclonal bands in the CSF. Acute treatment includes steroid, while chronic management involves interferon, natalizumab, and glatiramer. NMO is similar to MS, but is characterized by bilateral optic neuritis and the presence of aquaporin 4 antibodies in the blood. Differentiating NMO from MS is crucial for appropriate treatment. Moving on, ADEN is a post-infectious or post-vaccination demyelinating disorder, more common in adolescents. It presents with a single episode of widespread neurological symptoms and altered mental status. Confusion is always present. Differentiating ADEN from MS is important due to its more aggressive initial presentation. It's usually a single episode. Moving further, PML is caused by the reactivation of the JC virus in immunocompromised individuals, such as those on natalizumab. It leads to oligodendrocyte death and widespread demyelination, often resulting in rapid neurological decline. Moving on, osmotic demyelinating syndrome or central pontine myelinolysis results from rapid correction of hyponatremia. It leads to demyelination in the pons, potentially causing locked-in syndrome. Gradual correction of electrolyte imbalances is essential to prevent this condition. Moving on, Guillain-Barré syndrome is an acute demyelinating disorder of the peripheral nerves, often following an infection or vaccination. It presents with ascending paralysis and albuminocytologic dissociation in the CSF. In case you don't remember, albuminocytologic dissociation means there's a lot of proteins but very few leukocytes. In the liquor, of course. Treatment includes plasmapheresis and intravenous immunoglobulin. Do not use steroids in Guillain-Barré, okay? CIDP is a chronic counterpart of Guillain-Barré syndrome, presenting with chronic ascending paralysis. Early diagnosis and treatment with plasmapheresis and immunoglobulin are crucial for managing symptoms and preventing long-term disability. Finally, Charcot-Marie-Tooth disease is a hereditary polyneuropathy characterized by foot deformities and chronic peripheral neuropathy. It affects both axonal and demyelinating functions and typically presents in childhood or early adulthood.
Part 25.
Welcome to our session on neuro-oncology. Take-home points. Let's start with adult-onset primary brain tumors. The most common types include glioblastoma multiforme, meningioma, oligodendroglioma, hemangioblastoma, schwannoma, and pituitary adenoma. Talking about the first one, glioblastoma multiforme, or GBM, is a highly malignant grade 4 astrocytoma. It is characterized by GFAP positivity and histologic features featuring pseudopalisading cells and necrosis. GBM often presents with rapidly progressing neurological deficits and has a poor prognosis. On the other hand, meningiomas are usually benign tumors arising from the meninges. They are characterized by whorl spindle cells and psammoma bodies on histology. Meningiomas can cause symptoms by compressing adjacent brain tissue and are more common in females. Oligodendrogliomas are slow-growing tumors that often present in the frontal lobe. They are characterized by fried egg cells and chicken wire capillaries on histology. These tumors can calcify and are associated with seizures. Hemangioblastomas are vascular tumors often associated with von Hippel-Lindau disease. They can produce erythropoietin, leading to polycythemia. These tumors are commonly found in the cerebellum and spinal cord. Schwannomas are benign tumors of Schwann cells, commonly found at the cerebellopontine angle. They are S100 positive and consist of spindle cells and myxoid areas. Bilateral vestibular schwannomas are associated with neurofibromatosis type 2. And finally, pituitary tumors can cause hormonal imbalances, leading to symptoms such as hyperprolactinemia, acromegaly, or Cushing's disease. They can also compress the optic chiasm, leading to bitemporal hemanopia. Just so you guys remember, bitemporal hemanopia. You can't see the lateral sides. Okay? Now, let's discuss primary brain tumors that are more common in children. These include pilocytic astrocytoma, medulloblastoma, ependymoma, craniopharyngioma, and pinealoma. Pilocytic astrocytomas are benign tumors typically found in the cerebellum. They are GFAP positive and histologically characterized by corkscrew-shaped Rosenthal fibers, like this, very pinky ones. These tumors often appear cystic on imaging. Medulloblastomas are highly malignant tumors originating from the cerebellum. They are synaptophysin positive and feature small blue cells and homo-right rosettes on histology. Medulloblastomas can cause obstructive hydrocephalus and have a tendency to metastasize to the CSF and consequently to the spinal cord. Ependymomas arise from the ependymal cells lining the ventricles. They often cause obstructive hydrocephalus due to their location. Histologically, they show perivascular pseudorosettes. Craniopharyngiomas are benign tumors arising from the remnants of Rathke's pouch. They are typically found in the suprasellar region and can cause symptoms by compressing the optic chiasm and pituitary gland. Histologically, they often contain calcifications and cysts. And finally, pinealomas are rare tumors of the pineal gland that can cause Porinote syndrome, characterized by vertical gaze palsy. They may also produce beta-HCG, leading to precocious puberty in males. Now, let's dive into the last topic. Neurocutaneous syndromes are genetic disorders that affect the skin and nervous system. These include neurofibromatosis type 1 and 2, tuberous sclerosis, von Hippel-Lindau disease, and Sturge-Weber syndrome. Neurofibromatosis type 1 is characterized by caffeolate spots, neurofibromas, leash nodules on the iris, and an increased risk of optic gliomas. It is caused by mutations in the NF1 gene on chromosome 17. Moving on, neurofibromatosis type 2 is characterized by bilateral vestibular schwannomas, meningiomas, and ependymomas. It is caused by mutations in the NF2 gene on chromosome 22. A lot of chromosomes, I know, it's hard, but we'll get over it. Tuberous sclerosis is characterized by facial angiofibromas, ash-leaf spots, shagreen patches, in the presence of benign tumors such as subependymal giant cell astrocytomas and renal angiomyolipomas. It is caused by mutations in the TSC1 and TSC2 genes. Von Hippel-Lindau disease is characterized by hemangioblastomas, particularly in the cerebellum, retina, and spinal cord, as well as renal cell carcinoma and pheochromocytomas. It is caused by mutations in the VHL gene on chromosome 3. And finally, Sturge-Weber syndrome is a sporadic disorder characterized by a facial port wine stain, leptomeningeal angiomas, and glaucoma, ipsilateral to the port wine stain. Okay, the facial port wine stain typically follows the distribution of the trigeminal nerve. And that's it for now, folks. Hope you had a nice take-home points class today. Thank you very much, and good luck on your exam.